Hi, still on the continuation of diabetes mellitus. So we'll be talking about the pharmacologic therapy. First on the list is your insulin therapy. So you would notice that 15 to 25% of diabetic patients would require insulin. So who are these patients? Type 1, of course. All of the type 1 patients, as the term implies, insulin-dependent diabetes mellitus, they would need insulin therapy. Type 2 patients who are not responsive to OHA may progress towards your insulin therapy. And then your type 2 DM patients also during their acute stress. What do I mean by this? If I have a type 2 DM patient who is admitted, for example, on infection, and then the patient's sugar control is not good, your insulin may be needed. Or for example, if a type 2 DM patient will be undergoing surgery, insulin may be needed to augment on the other OHA that is being taken by the patient, or especially if the patient is on NPO and that no medications can be given. So this is what we meant by acute stress, because surgery or any procedure done to the patient may be considered also as a source of stress. And during stress, glycogenolysis and your gluconeogenesis also occurs. So there are several types of insulin. So you have your short-acting, intermediate-acting, long-acting, and then you have your premix. So when I talk about short, intermediate, and long-acting, short-acting are the ones which has rapid onset of action, and then shorter or shorter time for it to attain its peak action compared to the intermediate and long-acting insulin. For your premix insulin, these are insulin which are combination of your regular or intermediate, regular or long-acting, and then intermediate long-acting. So any of the combination of different kinds of insulin is considered to be your premix insulin. Your premix insulin would usually come in the form of insulin pens. Now, this is an important part when it comes to the differentiation of your insulin. The important is for us to know when is the onset of action and then when is the peak action. Okay, look at it. We're talking about regular insulin. The onset of action of your regular insulin is within 30 to 60 minutes. And then the peak will be on 1 to 5 hours. Meaning, okay, 1 to 5, that's around 4 hours. You would expect that your patient would have, on average, the risk for hypoglycemia after 2 to 3 hours after meals, okay, because that would be the peak action. So when I talk about regular insulin class, your regular insulin is the only insulin that could be administered IV. Okay, compared to other types of insulin, your regular insulin is clear. It appears to be a solution. Okay, it's clear. It's not cloudy. Since it's clear, it can be administered via your IV route. Okay, your other types of insulin class are cloudy, so they are not to be administered using your intravenous route. Okay, your regular insulin can also be administered subcutaneously, just like all other insulin brands or types that we have. Okay, now again, we focus on the peak. Remember that the peak time here is the time wherein the risk for hypoglycemia is very high. For example, if we're talking about insulin Rispro, look at it. The peak of action is at 30 minutes to 2.5 hours. Okay, so if you have noticed, if our patients are taking insulin, we are very strict on the advice that they should take their meals on time. For example, if they're taking regular insulin, in our setting, regular insulin is usually used if the patient is just starting on insulin. So we advise them that insulin injection should be done, okay, once the patient is able to eat, or once the patient is able to have the food already prepared on the table. It is not possible that they will be injecting their insulin and then they will be taking their food after 1 to 2 hours, because your patient will be at high risk for hypoglycemia. And class, when I say hypoglycemia, your patient will manifest with coma, and then some of them may manifest with even signs and symptoms like that of stroke. So that's why we do not just underestimate your hypoglycemia. It could result to coma and even death. So familiarize the onset of action of your regular insulin, your NPH insulin, and then the average for the long duration insulin. On this slide, you will see the onset of action of your mixed insulin. So as you can see, there are different types of combination, 70-30, 50-50, and then different kinds of insulin substances. So you can notice that the peak action is on the average at more than 3 hours to 4 hours. So the onset of action also varies because take note there are different kinds of insulin. Usually you combine short acting with an intermediate acting and then the long acting. There are different possible sources for insulin. So one is your pork, then you have your beef, and then you also have your human insulin. Ah, so commonly right now we're having your human insulin. With that being said, the allergic reaction to insulin have been gradually reduced over the decades. So if you can notice, there is a quote in quote there in the human because it does not mean that we extract insulin from another human being to be given to another patient. So when I say human insulin, these are usually genetically engineered insulin, which are reproduced in the laboratory setting with the use of some bacteria types. So for the storage, although it was emphasized there or indicated that the storage is refrigerator, take note that if we're using your regular insulin, okay, your regular insulin is placed in the refrigerator prior to first use. But when you are already using the insulin, let's say for the second, third, and the succeeding doses, this can be stored in room temperature. It is not advisable to be stored in the refrigerator because administering solution subcutaneously, which is very cold, could result to the dystrophy of your fatty tissues and would alter the absorption of the substance. Hence, it is best to be stored in room temperature. There are different concentrations. So you have 100 units, 80 units, and 40 units. Okay, with that being said, you need to be mindful that insulin is a high alert medication. Again, when I say high alert medication, an error on the dose could mean the life of your patient. Okay, a minimal error on the dose could mean the life of your patient. So what do you mean by that? You need to counter check before you administer your insulin. And then what's the syringe that you're going to use? You need to use your insulin syringe. Remember, there is a specific syringe that you refer to as insulin syringe. Okay, it contains marking which is appropriate for the number of units of your insulin. You are not supposed to use your tuberculin syringe as an alternative for your insulin syringe because the calibration or the marking in your tuberculin syringe is way different, okay, from that of your insulin syringe. It would mean hypoglycemic episode and maybe coma on the part of your patient. Okay, so route, so you have subcutaneous and intravenous. Recall that there is only one type of insulin that could be administered intravenously, and that will be your regular insulin, which would be clear in appearance. And then injection sites. Injection sites, anything. Talking about sub-Q. So wherever there's fat, you can inject your insulin. So these are examples. This diagram shows the common injection site. So we have your upper outer arm, we have your abdomen, buttocks, and then you have your upper outer thigh. Okay, so class, common nursing education when you are administering your insulin is to rotate the site. I would like to clarify that when you are saying rotate the site, it does not mean that you will inject at the arm on the morning and then in the afternoon dose you'd be injecting in the legs. Okay, when we say site rotation, it is on the same anatomical region. Let's say, for example, I will be continuously injecting on the upper outer arm, but it should be 1 inch away from the previous injection site. So again, when I say site rotation, it is just the distance from the previous injection site. It does not mean that you will be changing between regions. Okay, an inch of distance between the injection sites would already be okay. What is the purpose of the rotation of your injection sites? It prevents your lipodystrophy, okay, or your lipoatrophy for that matter. So other complications of your insulin therapy. One is hypoglycemia. So hypoglycemia is any blood sugar less than 80 or less than 60. So your patient may again manifest with signs of coma. So how can your patient prevent hypoglycemia? They need to take their meals on time. As mentioned, 3 meals and 2 snacks. You need to educate your patient that diaphoresis, tachycardia, excessive sweating, tremors, and then fidgety feeling, restlessness are signs of hypoglycemia. So if they are feeling this, okay, they need to check their blood sugar using their glucometer. If it's not within reach, you may advise them to have their sugar intake. Okay, your emergency candy perhaps, or your rescue candy. Then you have your tissue hypertrophy or atrophy, which can be prevented by your use of your insulin no, by the rotation of your insulin injection sites. And then for the erratic insulin reaction, we have your Somogyi phenomenon. You also have your Dawn phenomenon, which we will be talking about later on. Insulin allergy. So if ever your patient manifested with signs of allergy, let's say for example, hives, itchiness, okay, redness, swelling, okay, it needs to be referred right away to the physician for antihistamine medications to be given. Okay, as mentioned, insulin allergy have been already reduced because of the use of your human insulin. Then we have your insulin resistance. When I say insulin resistance, meaning at the same dose or higher dose, the blood sugar levels are not anymore responding. So it's as if that the blood sugar levels or the blood sugar is not already reacting to the action of your insulin. So that's insulin resistance. So this is usually done or managed with a combination of other hypoglycemic agents. Okay, perhaps the use of your OHA in combination with your insulin. Then, so these are reminders on your insulin therapy. You may pause the video and go through this material because this is an important reminder. I would like to emphasize that this is given subcutaneously. So if you're using your subcutaneous needle, which ought to be shorter compared to your IM needles, okay, it needs to be injected at 90-degree angle, okay, or 45-degree to 90-degree angle. Injection site. So for sub-Q injections administered repeatedly, so site rotation is recommended. So there are these three areas. No? The three areas are your AAT. You have your abdomen, your arms, and your thigh. According to this, the area of the abdomen would have the fastest absorption of all the insulin. By the way, class, when we are educating our patients on injecting insulin on the abdomen, we usually educate them to move far away from the umbilicus, because the umbilicus is very rich with blood vessels. That instead of subcutaneous route, your patient might administer it accidentally intravenously because of the rich supply, of blood vessels in the umbilical area. So again, the three areas are abdomen, and then followed by your arm, and then followed by the thigh. So that is in order of absorption. Then we rotate the site 1 inch apart, and then we avoid heavily exercised areas. Why are we avoiding heavily exercised areas? Because your exercise would increase the rate of absorption of your insulin. That would defeat the purpose why we are administering your insulin subcutaneously. So remember, your subcutaneous route, although it is considered to be parenteral, its absorption is lower compared to that of your IM route and then your intravenous route. And the purpose of that is to allow for gradual release of insulin to the bloodstream. Okay, it's just like having your basal insulin rate. Okay, as if your pancreas is releasing basal rate of your insulin. Hence, again, reminder, insulin injection is not usually done on heavily exercised body parts. Then, client who is taking 2 injections daily may use one site in the morning and another site for evening. We avoid excessive agitation of the bottle. So we do not shake it vigorously because that would prevent, okay, the loss of potency, clumping, and frosting or precipitation. Then, we administer insulin at room temperature, as I have mentioned. But when you are planning, to warm the vial, you roll it between your palms and you do not shake it. Then, the techniques for insulin injection. So again, 45 to 90-degree angle of a gauge 25 to 27. We do not aspirate for blood return when we are administering your insulin and heparin. Why is that so? It is not necessary in insulin. And if I'm talking about heparin, remember your heparin class is an antiplatelet. Okay, so your heparin being an antiplatelet, anticoagulant. If you are withdrawing, okay, for the blood sample during subcutaneous injection, you might just increase the risk of hematoma for the patient. Then, never massage the site after injection. Massaging the site after injection would again increase the rate of absorption of your insulin, which would defeat the purpose why is it administered subcutaneously. This is the insulin injection site form in Iloilo Mission Hospital. I think most of you are familiar of this from your related learning experience. So this is where we document where we have done the injection. Okay, in Iloilo Mission Hospital, also in their narrative charting, they would also indicate the site of injection. So these are your insulin syringes. As you can see, the calibrations here is up to 100 units. So as I've mentioned, 1 ml in tuberculin syringe is different from 1 unit in your insulin syringe. It's a very big difference. So you need to be careful in the use of your syringes. Okay, so take note, the syringes should be only single use. So these are showing your insulin injection sites. So as you can see, self-injection or self-administration is highly encouraged because patients will be staying in this medication for long periods of time. Then we have your insulin pump. So your insulin pump is an alternative method of insulin delivery. Your insulin pump is actually a pump which is implanted going towards the skin, okay, on the abdomen, going towards the subcutaneous area. So the dosage instructions will be entered to the pump's computer. It will be encoded. And that instruction would include what will be the basal rate, what could be the bolus rate in case there is a sudden increase of glucose. So it acts as your little pancreas. Then you have your insulin pens. Insulin pens are actually expensive. So these are combination of insulin. So what happens here, class, is that we change the needle. Okay, the needle here could be changed. For example, you have your Novofine needle, and then you just rotate it. Okay, if ever you would want to administer, for example, 20 units, you just need to rotate this until 20 units would appear. Okay, it's already pre-calibrated. And then its size is just bigger than the regular pens that we have in our locality. Okay, so those are your insulin pens, usually stored in the refrigerator when not used. Then you have your jet injections. So your jet injector would allow the insulin to spread over the larger area, okay, in the lower layer of your skin, which is your subcutaneous. And then the insulin would move into the bloodstream faster than it would be from a needle injection. So it's referred to as jet injection because it would entail a fast recovery or no, fast injection and fast absorption of your insulin to the bloodstream. Then we have your erratic insulin reactions. So one of your erratic insulin reaction is what we refer to as your Somogyi effect. Okay, your Somogyi effect is oftentimes described as rebound hyperglycemia. So what do we mean by rebound hyperglycemia? Class, at bedtime, these patients would have normal or increased blood sugar levels. At 2 a.m. to 3 a.m., they would have decreased blood glucose. So they would oftentimes present in the clinic and then would complain that early in the morning, okay, let's say for example 3 a.m., they had episodes of headache. They had night sweats and then nightmares. Class, those are manifestations of your hypoglycemia already. And then at 7 a.m., there will be rebound hyperglycemia. How come rebound hyperglycemia? The body was able to detect that there is a decrease of glucose. So as a counter-regulatory hormone, okay, which might be the effect of your glucagon, okay, there is an increase of your blood sugar levels at around 7 a.m. So, how do we address this now? The management for this is to decrease the insulin evening dose. Because if you would look at it, class, okay, our concern is that at 2 a.m. to 3 a.m., there was an episode of hypoglycemia that later on at 7 a.m. led to hyperglycemia because of negative feedback and counter-regulatory hormones. So, for us to prevent the occurrence of early morning hypoglycemia, we would decrease the evening dose of the insulin. Okay, take note, evening dose of insulin. It usually acts at 2 a.m. to 3 a.m. So what kind of insulin are we talking here? So it may be your intermediate acting insulin. Then after that, we also advise the patient to increase their bedtime snacks. Plus, the purpose again of this management is just to prevent hypoglycemia to our patient. Then you have your dawn phenomenon. Class, when I say dawn phenomenon, dawn, okay, so it's early morning hyperglycemia. So this is caused by excessive early morning release of your growth hormone and your cortisol. Class, your growth hormone would trigger, okay, the glucose, also your cortisol. So management for this patient. So we increase the insulin dose or change the time of your insulin, okay, to address the early morning hyperglycemia. Then we have your honeymoon phase. So class, your honeymoon phase, okay, we need to educate our patients on this because once your patient is newly diagnosed with diabetes mellitus, there may come a short period of time wherein there is disappearance of symptoms on newly diagnosed clients. Okay, then what usually happens, the patient would think that they are already okay For that reason, we always tell them not to stop their medications abruptly, and that sugar control is not attained within just matter of weeks. Okay, it needs to be a matter of months of treatment. Usually, repeat laboratories are done after 6 weeks of therapy. Okay, but after 6 weeks of therapy, we do not expect blood sugar control yet for most of our patients. Then you have your oral hypoglycemic agents. The action of your oral hypoglycemic agents is twofold, depending on its specific classification. So your oral hypoglycemic agent may stimulate your pancreatic beta cells to release your insulin. Again, it stimulates your pancreatic beta cells to release your insulin. It also decreases your gluconeogenesis by the liver. So if you would look at it, the main goal is to decrease the blood sugar of the patient. So it could be your sulfonylureas, such as your diabetes and your urinase, and then you also have your biguanides, such as your fenformin and your metformin. So commonly you can hear about metformin. So what are the criteria for prescribing OHA? So you have over 40 years of age, no history of ketosis. The patient should not be pregnant. Okay, why pregnancy? There was a time when in your oral hypoglycemic agents were found to be teratogenic. Okay, so that's why it's not usually given to your pregnant patient. Then on less than 40 units of insulin per day. And then for those who has mild to moderate signs and symptoms of hyperglycemia. Okay, once the insulin is more than 40 units already, class, okay, you would not opt for having the patient on OHA. Okay, rather, you would have your patient on insulin injections. Then, so you have your oral sulfonylureas, example of which again are your glimepiride, your glyburide, and then your tolazamide. Take note that the action is to trigger the pancreas to make more insulin. Then you also have your biguanides. The action of your biguanide is to decrease the liver production of glucose, meaning in other words, it prevents your gluconeogenesis, okay, in which it would try to decrease also your blood sugar levels. Then you have your thiazolidinediones. Okay, your thiazolidinediones are used for type 2 diabetes mellitus with insulin injections but inadequate control. Okay, meaning in other words, the HbA1c is at greater than 8.5. Recall that I mentioned that the target may be 6 to 7 for your HbA1c. So examples of this is your risoglitazone, and then you have your pioglitazone. Okay, so commonly we use this in combination also with other OHA. So again, your thiazolidinediones is for type 2 diabetes with inadequate blood glucose control. Then you have your alpha glucosidase inhibitors. So the purpose of your alpha glucosidase inhibitor is to delay the absorption of glucose in the intestinal system. Okay, so it acts on the intestines. It decreases blood sugar absorption in the intestines. So what would be the result? It would lower your postprandial blood glucose level. So when I say postprandial, that is your blood glucose level after meals. Okay, common examples of this is acarbose, and then you have your miglitol. Now, you might be wondering, why are there different classes of oral hypoglycemic agents? So class, just like how your pain medications would work, okay, in the management of diabetes, combination of different types of oral hypoglycemic agents may be needed to ensure blood sugar control. Okay, because remember, our blood sugar control is not only controlled by one hormone. Okay, that's why we need to have several approaches for us to control the blood sugar properly. That's why you would encounter patients who take combination medications. For example, okay, in the market, there is combination of your metformin and your pioglitazone. There are even triple combination of medications. There is a medication that would combine glimepiride, pioglitazone, and metformin. Okay, so the purpose of this is to have different approaches on attacking your blood sugar levels. Okay, so what are the side effects of your OHA? One is hypoglycemia. So the advice is still the same. You need to have 3 regular meals and 2 snacks. Skin rashes is a sign of allergic reaction, so inform the physician. GI disturbances is common, especially if your patient is starting on the therapy. This is a common reason of non-compliance when it comes to your oral hypoglycemic agents, particularly your metformin. Several patients would complain of epigastric discomfort related to metformin. So our advice to our patients is that they do not stop the therapy. Okay, they need to be on the therapy within a week or 2. Okay, usually class their epigastric discomfort would resolve after 2 weeks. Severe flushing may occur. Nausea and vomiting may also occur. Whenever there is persistence of these symptoms, they need to go back to their healthcare provider to discuss other options. Now, surgical management. This surgical management is rarely done in the Philippine setting. So you have your pancreatic transplant. Okay, so you have your PTA. When I say PTA, pancreatic transplant alone. Then you have your PAK, your pancreatic pancreas after kidney. And then you also have your SPK. And then you have the implantation of insulin-producing pancreatic islet cells. So that's what happens during your pancreatic transplant. Now, try to ask, what could be the possible relationship? Why is that the kidney and the pancreas are being transplanted at the same time? Is there any relationship between this? Okay, you try to read on that. Now, here are the possible nursing diagnoses for a patient with diabetes. Knowledge deficit, okay, may be related to lifestyle changes, dietary changes. So, knowledge deficit, you need to educate your patient. Not just educate, you would need to follow up. Okay, we usually give our patient diet exchange list. We give them diet list on their options, but you need to follow up. Okay, because some of them are not telling you, but the food options available on your list are not available in their locality. Then potential for injury related to hypoglycemia. So orient them that by the time that they're feeling tremors and then palpitations and then diaphoresis, these are signs of hypoglycemia. They do not wait until they lost their consciousness before they act on it. Then fluid and electrolyte imbalance may also occur. Then non-compliance to treatment, okay, due to lack of motivation, financial problems. And then anxiety related to current symptoms. That's why you need to allow your patient to verbalize their feelings. And then potential for impaired skin integrity. So I've mentioned your patient may have neuropathy. When I say neuropathy, the sensation of your patient is impaired because of the increased blood sugar levels that damages the nerves. To that effect, okay, these patients are not supposed to be applied with hot water bag because what may be hot to us as normal human beings may not be hot to them. They may not be able to feel it. Okay, by the time you remove your hot water bag, your patient is already experiencing your first degree burns. So need to be careful with that. Extra caution on that. Okay? On the succeeding recording, we will be discussing about the acute complications of your diabetes. Okay? Thank you very much for your kind attention on this one.